Hey team, welcome to another episode of Ortho Out Loud. I'm your host, Scott McKay. Aging is inevitable, and training for a 5K can look a lot different at age 50 than it did at age 25. Just because our bodies change as we get older doesn't mean we have to become less active. In today's episode, we'll be discussing how to train smart, stay strong, and avoid common injuries that tend to sneak in with time. Here to help me discuss this topic is none other than Dr. David Morawski. Dr. Morawski has been a joint replacement specialist and surgeon here at Fox Valley Orthopedics for over 30 years. Welcome, Dr. Morawski. Can you tell us a little bit about your legacy here at Fox Valley Orthopedics?
Well, good morning, Scott. Thanks for having me. And yes, I've been here for over 30 years. I can't believe it. It's gone fast, and I think I've spent working side by side with you for over 25 years. So it's been a pleasure.
For me too, for sure.
Yeah. So, what I've been doing as it pertains to this podcast is I've been trying to keep people moving for over 30 years. A lot of people come to me with aches and pains and bad hips, bad knees, and we've been putting new ones in so they can continue to be active. So that's been my major part when I joined the practice. The forefathers, the founding fathers, Dr. Wittenstrom, Denker, and I could go on and name all the five guys before me. But I was the sixth, and the current senior partner now that's been doing this the longest, but I was the first one to join that was really interested in only doing hip and knee replacements or a subspecialist. So that's what I've liked to pride myself in, is taking someone who's barely walking to the mailbox and now they're walking or possibly trotting or jogging in a 5K.
Excellent. Can you tell us a little bit about your journey to becoming an orthopedic surgeon?
Well, to become an orthopedic surgeon, that's interesting. When I was younger, in the 60s growing up, we had family doctors, and we always thought, when my parents took us to the family doctor with a broken arm, some strange guy would come in and put a cast on me, but the family doctor would give us the instructions. And little did I know back then, those were the specialists that were really helping people treat. And I kind of found that out as I went through medical school, that there was more than just being a family doctor, that you could actually be a surgeon and help people. And in my career, I've kind of gravitated towards orthopedics because I was an athlete, a former athlete, played a lot of sports in high school and kept busy through college. So I always thought that I wanted to do something that would help people keep active. And I knew I wanted to be a physician, but I wasn't the kind of physician that would like to carry a stethoscope or write prescriptions only. Mm-hmm. So I knew I had to work with my hands. And when I started in the 80s, joint replacement was just starting to get popular in the community hospitals. In the 60s and 70s, it was done only in the universities. Mm-hmm. So as I got closer to my end game of medical school, I picked orthopedic surgery because I thought it had the option to help young people who had maybe deformities or birth defects, the athlete in the middle age, and then our senior patients. So I got to see the gamut of a whole family, and then I chose joint replacement after going into orthopedics.
It's interesting how over that time span, it seems like we see more and more younger patients who are undergoing joint replacement lately. Have you noticed that as well?
Yeah, that's an interesting fact. I mean, when I started in 1993 here, it was pretty much unheard of to do any joint replacements on people younger than 65. So when I started, we did a lot of what we call osteotomies, where we would realign the bone through cutting the bone, fixing the bone in a different position to kind of rotate your tires a little bit. We call those osteotomies. That was the proper thing to do in the young active patients or the laborers. But with the advancement of the materials in joint replacement, the better plastics and the better designs and the 3D printing, we're now able to get longer acting or longer lasting implants that can hold up to an active lifestyle like a younger person. So we've seen patients go through those osteotomies and not do very well and still limp and still have pain, and then come to the conclusion that they need a joint replacement at age 60, and they're very difficult reconstructions. Mm-hmm. So it's probably better to get someone in their 40s, 50s, do their joint replacement. They'll have a better, longer lasting and more fruitful life rather than going through some of these other things that we used to do. So that's why I think they're younger, because we know these implants can withstand the rigors of that younger lifestyle.
Very interesting. Running over 50 requires a different approach, but does that have to be off limits for patients?
No, I think I see a lot of my patients that are runners in their 50s or over 50s. And, being over 50 myself, I think at that age 50, it became more difficult to run. I certainly didn't want to sprint. In fact, I noticed, remember when we used to play softball?
I do, yes.
And I was in my 40s, and we used to have a rule that if you were in your 40s, you had to play infield, and only people under 40 could play outfield because you had to run farther. And how many of us pulled hamstrings and groins and everything when you're in your 40s? So we realized that you can't sprint fast even when you're 40 unless you do a lot of special training and stretching and so on. But, to get up, and we call them the weekend warriors like we were. We'd come out of clinic, barely dress in the car, and come right out of surgery and barely stretch,
right.
And we'd pull a hamstring or something. But now with proper training, I think 50, 60, 70-year-olds can run. And I admire those that can. I've been probably unfortunate to inherit my mother's genes, who had bad knees. So I'm starting to feel the effect of the genetics that play in my life. So I don't feel like running at this point, but I possibly wouldn't look pretty.
But just to stay active, I believe, is probably very important.
Correct.
Yeah. What do you think some things are that people can do in order to prevent injuries as we age?
Well, again, training, working up to it. Try not to do too much too quick, because you'll be set back. So when you get older and if you had a sedentary lifestyle, I tell patients, ease into it. Walk briskly. Walk for a mile, not 5 miles. You'll get sore feet, you'll get sore everything, And so I think it's starting slowly with a walk and then increasing the speed, the cadence, and possibly to a jog or even a light run.
And do you feel like some of your patients who have bad knee arthritis or hip arthritis, that they should maybe avoid some of those things? Or do you think it's better to move?
Well, Scott, being my PA for several years, there are some patients just aren't built for running. Their body habitus, their weight could potentially do more harm than good. So we ask those people to do less weight bearing or less pounding on the concrete, and maybe something like a softer treadmill, softer cushion, maybe an elliptical where they're not lifting their legs up and pounding on the concrete. But I think you have to modify to accommodate your body style, your weight, and your age.
And so it sounds like there's a lot of different options for people out there. Even if running is not the thing for you, there's definitely other options for you.
Absolutely. Keep active. And, I've transitioned personally from when I couldn't run anymore, and I used to have a treadmill. I have what's called an advanced motion trainer. It's kind of a hybrid between a treadmill and an elliptical. So my feet don't actually lift off and pound down. They stay on the machine, but they allow me to increase my cadence, where ellipticals have a fixed cadence, a certain width that you can spread your legs apart when you're going. This has the option of being a stair stepper or a incline or wide run almost motion. So it helps, and it relieves your joints. So there are different machines. I know of a lot of patients who just like to swim to get their cardiovascular activity.
Which is a non-weight bearing type activity, and you could do water aerobics as well, right?
Absolutely. I have a ton of patients that are in our local facility here where they have water aerobics that eventually, even after that, they come to me with bad hips and knees, and we fix them, and they get back to that, and they love it. They can't wait. One of the questions is, when, after a joint replacement, can I return to my water classes? And the answer is typically 6 weeks.
You bring up an excellent point about staying in shape and exercising after joint replacement. I would like to get into that a little bit more. Before we do that, however, can we talk a little bit more about different training that people should be doing, different exercises that people should be doing before their joints wear out so much that they're ready for a joint replacement?
Well, that's a broad question because everyone's different. I think everyone should stay active. We're humans, and humans are meant to be mobile. We're meant to be on our 2 feet, walking and moving around. So making sure you get your steps in. And I know everybody wears, like you have,
Yep.
these Fitbits and these Apple Watches and things to count our steps, because it's sort of rewarding when we can kind of look at a goal and we try to achieve it. And we notice when we step on the scale, if we got our steps in that week, every day, 10,000, that we didn't really gain too many pounds. So we try to stay active. And as we age, it becomes harder to stay active because we naturally lose muscle tone. And muscle tone, as you see, and as you may notice, well, you've known me for 30 years, where I probably was a lot buffer in my 30s and 40s and 50s. We started to atrophy a little bit, and you had to really work on your muscle strength to keep it up so that we can continue to be an active person. Getting out of a chair requires muscles, not just good joints. So if we don't pay attention to our muscles that move our body, and we don't train those and get those in shape and stretch those, we are going to have problems when we try to get up and run right away. So you have to constantly work on muscle tone and strength versus, just working on aerobic activity.
That's something that I've heard. Now, this is the third time from probably 5 different people who have come on this podcast saying how important, not just thinking about your joints or form, but how important muscle mass is, and not just in your legs, but your core and other places. And do you feel that training and working on muscle tone and core strength is important, not just for running, but for other activities?
Of course. It prevents injury. The core is a key. As a surgeon, I notice that if I don't work on my core, I have bad back after surgery, or leaning over a table, poor posture. So you got to have a good core for that. Otherwise, you're going to get sore. You're going to get injured, and so I'm sure it can translate into the desk workers or the people who stand all at a cashier or retail. So you work on your core, and that means not just weightlifting, but some type of core exercises, like, I'm trying to think of the words, planks and some kind of sit-ups and things like that work on our abdominal muscles, something that is really the key to preventing multiple injuries. And I'm not just talking about, it's a lot of guys want to come in and just work on their biceps and their chest and do that. But there's a lot of other things that help us prevent injuries. As you know, being an orthopedic PA, one of the biggest things we see is back pain. People with they lift improperly, they strain their back. So I think the core is what they're neglecting when we see people with back pain.
Yeah, and patients who look like they're in great shape, who have great muscle tone, but come in, like you say, with back pain because they're either lifting improperly or maybe even doing too much of one type and not focusing on others.
Exactly.
And I think that really kind of brings back the importance of cross-training, some days working on cardio, some days working on different muscle groups in order to have good balance for our whole body.
I think cross-training is a key, and it's hard to work every body part every day. So it's a good practice to let them recover for a day or two. So I was in a practice where it worked well for me, and I think my patients probably could learn from that. One day you do legs, the next day you do your chest, next day you do your arms, and now you're 3 days from your legs, so your legs are starting to recover, and you can go back to that. So you can kind of rotate through those. And a little bit of cardio, whether it be elliptical, advanced motion trainer, a bicycle. A lot of people have the Peloton or the other bikes that they can go on a ride across Japan, virtually, and it's kind of keeps them interested. Or they take classes. Mm-hmm. So a lot of people do different things. I know Orange Theory is a big thing now. My PA, Alex, goes to that every morning, and she's dedicated. I think it's about getting into a routine and staying, committed to be able to stay healthy.
And it sounds like there's a lot of different options. So if you try something and it doesn't work quite well for you, try something different, because there are a lot of options and different things to try.
Oh, absolutely. And as I get older, I think, and for my older patients that are my age or even older, I think just walking. It's amazing how good an exercise walking is. I always was a naysayer. Oh, I can't lose weight or stay in shape by just walking. I got to run. I got to sprint. I got to do intervals. But that's not true. It's particularly when you're older. I think you can walk. You can work on pace. You can just work on increasing your distance, and all those things pay off because the biggest muscles in our body are our leg muscles, our thighs, our calves, and those burn a lot of calories. So they definitely, just by walking, are a good way of staying fit and keeping your calorie count balanced.
And so accessible, right? There's so many interesting places you could go to walk, whether it's along a river or in a forest or down a city street that might have cute little shops or something of that nature.
Exactly. And stairs, if you can continue to do stairs, they add a whole nother dimension of ambulation and strength that are necessary. And uneven ground. So if you're like hiking on trails, my wife and I like to go to different national parks. And most recently we went to Shenandoah National Park in Virginia. And for the first time that I went through the gift shop, instead of buying like a souvenir cup or something, I bought a walking stick because I realized that my knee was bothering me. And I saw the hiking trails that my wife wanted to do, and I'm thinking, going down the hills and all these things, I want something to prevent me from falling and to take a little pressure off my left knee, which was bothering me at that time. So I think I would encourage people to do things, whatever it may be, to continue walking, whether it's using a walking stick or that little shillelagh that you have there.
Something like that one?
Yeah, that's quite impressive there. I know a patient gave that to you or something.
My parents actually gave this one to me for Christmas one year, and it's just about a perfect height, and it's got a nice handle for me to hold on to, just like this. And if there are any coyotes or lynx or anything, I could threaten them with the other end of the shillelagh. I don't think I would try to threaten a bear, though, or a moose, or a buffalo, for that matter. I don't think this will scare them, but...
My kids were kidding me when I was, I forget what holiday, it might have been Christmas, they asked me, or my birthday, asked me for lists, hey, Dad, what do you want for Christmas? And I on one of the websites I was surfing, I got this, it was like this, but it had multiple tools, like a knife, a saw, a flint, so in case like you were...
Like a Swiss Army walking cane.
Yeah, a Swiss Army walking cane. And they looked at it, and it was like 130. Dad, what do you want that for? I go, well, if I'm going to get a stick, I want something that's going to be useful.
That sounds like a great way to bring tools along with you that you might need and still stay active. Excellent.
Well, other options, I tell my patients, if they have a knee that's sort of worn out on one side, they should get a brace that we can help them, and they could increase their distance without having pain. So it may be a little bit uncomfortable for a while until you get used to the brace, like anything, and it has to fit properly. And yeah, I see you have a brace right there. That's one of the braces that I commonly prescribe on my patients, and it's amazing how people tell me they love it, and they come back after it wears out in about 6 months because they use it all the time to cut grass, to go for walks, to exercise, to go to the grandkids' games, which is, the 10th field down the road from the parking lot, and they have to walk that far. Those are all things that I'm learning because I have grandkids now that I'm going to their soccer games or softball games, and I'm looking for the closest parking lot.
But very good ways to stay active, maybe without medicine, without those side effects that you might get from medications, using something to take some pressure off of your hip or knee, like the brace or like the walking stick or a cane, to keep you active and keep you moving further.
Correct.
Lace up and hit the pavement at this year's Elgin Valley Foxtrot, a local tradition that brings runners, walkers, and the whole community together. Whether you're chasing a new PR or just out for fun, with 5K and 10-mile options, this race is truly for everyone. Don't forget, race day is Sunday, June 1st. And don't wait, registration is now open. You can use code FVO25 at checkout to save 10% on your registration. Let's make this year the biggest Foxtrot yet. We'll see you at the starting line.
Dr. Morawski, you've given us some great information about how to stay active despite some aches and pains in our hips, our knees, our backs, elsewhere. What do we do, though, when patients have tried these things, have tried canes, have tried different braces, medications? How do we help these patients out?
Well, that's a good question. That's what I do most every day. People come to me, and I have to sort out how many of these things they've tried. And they usually come to me frustrated that they're not able to live active lives anymore. They'll tell me, I'm only, 50, I'm only 60, I'm only 70, whatever it might be.
Sure.
And I should be able to, I feel like I'm a grandma or a grandpa, and I can't, stand very long. I can't walk very long. I can't go on vacation with my children. I can't go to Disney. So they get frustrated because they can't stay active, and let alone try to run in a 5K or 10K or any Ks. So that's the patient that comes to me with the need for sometimes surgical help. And of course, we do the full evaluation and find out what the root of their problem is. Is this sore muscles? Is this a torn cartilage? Is this a bad labrum? Is this arthritis? Is this bone on bone, no cushion in the joint arthritis that's preventing them from doing the things they want to do every day? So once we get a firm diagnosis with whatever testing, examination, and x-rays, and possibly MRIs, we'll present them with a plan, whether it be cortisone, gel, platelet-rich plasma, which is a biological healing of the joint, or possibly joint reconstruction. And joint reconstruction is what I would say the last resort for patients, but they come to me pretty convinced, knowing that they're headed in that direction. So my job is to prepare them medically, emotionally, psychologically, social, economically. It requires sometimes stopping their job for a while and getting back to work gradually, depending on what they do. So it's a challenging thing, but my job is to help them get better and to attain the lifestyle they want to live.
And what does that recovery look like, both short-term and long-term?
So today, total joint replacements is as easy as it's been since I've started practice. Now we do these outpatient in a surgery center that, when I started, we couldn't do my cases there. I had to go to the hospital where they sometimes came the night before or early in the morning and stayed 3 to 5 nights. Now they come in the morning at our surgery center, have a regional anesthetic, which is typically like an epidural or a spinal, and they're sedated so they don't remember or hear anything. The surgery is less than an hour, and we numb them up on the inside to last for 3 days. So they really have some pain, but not the pain that they used to have years ago. And they're upstanding and walking the day of surgery, of course with a walker, cane, or crutches, until they feel like they can trust their artificial leg or knee or hip, and then go without that many times a couple weeks. I think most of my patients are back to playing sports like pickleball, golf, tennis, somewhere between 6 and 8 weeks.
Wow, that's really amazing. It has come a long way since when I first started as well.
Yeah.
Those overnight stays in the hospital. And then just to have those first few days, which are usually the worst days, I remember having not as bad because of that long-acting local effect of the anesthesia.
Now, do you remember those days, rounding? We'd have to meet at the 7 o'clock, make rounds on 5, 6 patients.
Right. Exactly. Change
So
dressings.
being a PA now is a lot easier because they don't have to go do all that. It's for me, too. The life for us has changed for the better.
And only because we wanted to make it better for our patients, get them home sooner, get them to their own environment where, like you say, some of those emotional comfort level would be more, and give them confidence afterwards that they don't have to rely on a nurse, that they can do these things. And then you had mentioned that many of your patients are back to some of their activities within 6 to 8 weeks almost. How do they get back to those activities?
Well, they're very eager to do it, and some are more motivated to do it. The people who are, golfaholics, or they want to get back to that swimming class that the aquatic therapy classes. They're very motivated to get back to Orange Theory and all those things. So I really don't have to tell them to do it. They are asking me, when can I do it? And it's a matter of seeing how they're walking. I think the guideline after a joint replacement is, are you still limping? And if you're still limping, maybe you need to use that cane a little bit longer. Some people try to be stoic and try to show that they are recovering so fast, but they're walking awkwardly. Until the form of walking gets back to normal, the function can't return. So I tell them they have to walk without a cane, without a limp, and then they can slowly go into sporting activities like golf, tennis. But everyone's different. I have some real, all-star patients that will walk in, do squats at the front desk a week after surgery, and then others that are still walking in with their walker in 6 weeks because their confidence isn't as good, or maybe their pre-surgical conditioning wasn't as good.
And so just like training for a 5K, everyone's journey might be a little bit different. The important thing is to do what's best for your body and to make certain that you stay on a good road to recovery and listen to advice from your medical providers.
Exactly.
Do you find some of your patients do get back to running?
Well, I do. I would say those are the little bit younger patients. So if you take a 70-year-old who hasn't run in 20 years, they usually don't have the interest to run. Mm-hmm. So I don't think that patient hasn't run in 20 years, I do a knee replacement or a hip replacement, they're going to start running. It's those 45 to 55-year-olds who still want to play after work softball and they want to run the first base. And I remember one guy, I told him, back in the old days, we told him not to run when joint replacements weren't as durable and the plastic would wear out quicker. And I remember telling a specific patient back then, you probably shouldn't run. Oh, doc, I hit an inside of the park home run. And that requires a lot of quick running around the bases unless there's a real slow guy in the outfield can't get the ball. But nowadays we tell people they can run on the current materials that we give. And it was hard for me to start telling my patients that because I was so used to the old rules. Mm-hmm. But when I've gone to all these academy meetings and joint replacement meetings and what the teaching is now from these materials, they've been tested in the lab and on all these, with a cadaver knee, and they test the wear with pounding and running and simulated running, and they last a very long time. So for people who want to jog a little bit, maybe intermittent walk and jog, or run the first base, and then, not maybe marathon runners. Mm-hmm. It's probably not a good idea to put that much stress on an artificial joint. I suppose it can. I haven't had any marathon runners or anyone who ran a marathon with a joint replacement yet, but I have people who do jog around the neighborhood, that go around the track and do play softball, tennis, ski, water ski, snow ski. So all those things are fair game now.
It must be really rewarding to see those things change over the years, to see your patients happier and more active. That's probably the most rewarding thing of the practice that I have. I get to see very appreciative patients, and that's what keeps me coming back. Now, there might be a day or two where we have not a success story, but those positive responses from patients far outweigh those negative ones that we do get. And then for those patients who are more active, is it important for them to come for more close follow-ups?
After joint replacement, typically if a patient gets through the first 1 year, we then decrease the frequency that they need to come back. So we usually see our patients at 1 year, frequently the first year, but after 1 year, then it's 3 year, then a 5-year checkup, and then every 5 years for repeat x-rays. And just to get a check and a baseline and a progression. So if something starts to feel funny in the knee, we can go back and look at serial x-rays and see if there's any evidence of something wearing or loosening.
And what would be some signs that maybe somebody should come in sooner?
Pain, swelling, instability.
Don't just ignore those things.
Don't ignore those. Come in, let's have it checked out. I can just think from yesterday, I had a patient who fell. Mm-hmm. Didn't know she's hurting and fell on his hip and his shoulder, but I had a hip replacement in there and he wanted to make sure nothing was broken, so he just come in for an x-ray. You don't want to wait too long. We have a walk-in clinic here, every morning from 8:30 to 8 o'clock at night. So Monday through Friday and what is it, 8:30 to 2:30 on Saturdays.
Correct. Or 8:30 to 2 Saturdays. And a simple test, right? A simple x-ray can give us so much information.
Absolutely.
Do you find that some patients who are exercising after joint replacement still have some issues with pain and swelling?
Well, not so much swelling. If there's some swelling, after a year, I get a little more concerned. I do know that people with artificial joints can still get pain because, as you know, Scott, we don't replace their muscles or their tendons. And if they're 65-year-old muscles and tendons, they're going to get sore if you overwork them or overuse them. If you do too much stair stepper or too much climbing stairs, you might get patellar tendonitis. If your muscles aren't used to doing a lot of leg exercises and squats, you're going to get sore, screaming muscles that are still yours, not artificial, and have nerve and pain fibers in there. So those people can get that, and we have to differentiate whether there's something wrong with the implant versus a tendonitis or bursitis.
Dr. Morawski, thank you so much for spending some time today talking about our patients and joint replacement. It really has been a pleasure reviewing some of our old patients and reminiscing for sure, especially about those softball days.
Yeah.
And you're right. We had a whole list of people on the team with different injuries, but we still won the trophy that year, so that was exciting. Now we're going to transition to our rapid fire questions. These are just some fun questions for you to answer. They'll give us some good advice as well as some good insight into you. So I'd like to start out by asking, what is your favorite hobby outside of the gym?
Golf.
Yeah, I was going to say that's an easy one. I could have answered that for you, I think. Do you prefer a morning or evening workout?
Morning.
Yes, for sure. The foam roller, is that a friend or foe?
Friend, but I don't like to use it because I don't like having that injury that you have to use it.
What is or what would be your go-to karaoke song?
Ring of Fire.
You would do good with that, with the little
Johnny Cash.
Yep, for sure. And from the commercial that you remember regarding that as well. What fashion trend you hope never comes back?
I would say, well, I don't know. I like a lot of different fashions. Probably the 80s with the poofy pants.
I was going to say the parachute pants.
Parachute pants.
Yeah, that would be the one. I agree with you.
I never wore those. So, but I
say,
like bell bottoms.
I did have a girlfriend.
And platform shoes.
She wanted me to get those, so I did. I wore the parachute pants.
Is that girlfriend your wife now?
She's my wife now. That's correct. What is something people are always surprised to learn about you?
That I have a motorcycle.
Bone saw or scalpel? What is your preferred instrument?
Scalpel.
And then last question. Do your friends ask you for medical advice at parties, and do you answer them?
Yes, and I do.
That's because you're a very friendly person. I've never met a person that you couldn't talk to and have some very good relationship with. I really appreciate you coming on the podcast today. It's been great talking with you.
Thanks, Scott.
Take
care, buddy.
You too. Thank you for joining me for another episode of Ortho Out Loud. Dr. Morawski unfortunately had to run to go to a surgery, but I really appreciate the insight he gave us regarding training after age 50 as well as after joint replacement. Yeah, and I hope you all got good pointers out of that no matter your age. And please feel free to comment on social media. We'd love to hear from you, and we're also trying to come up with a nickname for all of us who listen to the podcast. So if you have any great ideas for that, I'm definitely open to listening to them. Thanks again for listening and watching, and have a great run. This podcast features insights from orthopedic specialists at Fox Valley Orthopedics. While we hope you find these discussions helpful, we are not giving you medical advice or providing opinions about your specific medical conditions or concerns. The views expressed on this podcast are not a substitute for personalized medical advice. If you have questions about a medical condition or treatment, please consult your own trusted healthcare professional. Never ignore professional medical advice or delay seeking care because of something you heard on this podcast. The views and opinions expressed by the hosts and guests are their own and do not necessarily reflect those of Fox Valley Orthopedics or its affiliated organizations. Any decisions made based on the information provided in this podcast are done so at your own risk, and Fox Valley Orthopedics disclaims and is not responsible for any actions taken as a result of this content. If you are experiencing a medical emergency, please call 911 and seek immediate medical attention.